slide number 1.
Okay, so it looks like we have a really large shave, and then it looks like there's this large collection of basaloid cells. It's kind of hard to tell, low power, what's going on, but staying low power, I can see just at the periphery, there's eosinophilic material surrounding this basophilic material. A lot of spindled cells for these basaloid cells, and then looking at the left of the eosinophilic material, it looked like there was like some Calden trapping. So this definitely is busy enough to be a DF. So I'm thinking it might be a DF.
Yeah, so this is actually a cellular or a xanthomatized DF. It's a pretty big lesion, but it's completely benign. And so you can see here that there is the swirling kind of like a pattern, but there is admix actually, like if you look closely at the lesion, they're also inflammatory cells, they are histiocytes, they are giant cells. So all of that is indicative of a benign process. So this is a xanthomatized or a big giant dermatofibroma. Okay.
Nice.
Let's go to a slide number 2. Okay. Here.
All right, just from this power, looks like it might have a granulomatous process going on here. They seem to be more sarcoidal than tuberculoid.
Okay.
Looks like there's some giant cells mixed in there. I'm not seeing any areas of caseation necrosis or anything like that. Yeah, I'm not seeing any obvious foreign bodies or
Yep.
So maybe just sarcoidosis.
Yep, this is sarcoidosis. You see, these are very beautiful. Even though there is a lymphocytic infiltrate, these are not tuberculoid, these are sarcoidal. You can see a beautiful multinucleate giants, a very classic for cutaneous sarcoidosis. These are very pink nodular aggregates forming these little fluffy clouds or, fist bumps, pretty good for cutaneous sarcoidosis. And the pattern lichenoid perivascular is very consistent with just primary cutaneous sarcoidosis instead of like, the back-to-back sarcoidal granulomas, which are more, you will think about like a foreign body. So great. So everybody got that?
Yeah, good.
Yes, slide number 3.
They got a really superficial shade here. It looks like we have some hyperkeratosis, and then it looks like we have some cleared out cells there. It kind of look like those birds' eye cells.
Okay.
Look like a verruca plana.
Yep. Yeah. You're absolutely right. This is a verruca plana, a very important question, definitely be going to be there. It's always very subtle papillomatosis, but when you go up on high power, you see the hypergranulosis and you see the coilocytes, the cleared out cells, which you would expect to see in a verruca plana. Yes, yeah, absolutely. That's correct. I'm going to put up the slide 4, and then I'm going to quickly just take this call for a minute.
Okay.
Okay. I'm just going to put you guys on mute. Okay. So we're back here. So what do you think this is?
All right. So looks like we're on a thick acral surface here, thick stratum corneum. See the stratum lucidum there. there's a little bit of superficial perivascular inflammation going on. I don't see like a lot of edema or anything, so I don't think it's pernio. Looking up in the stratum corneum, I was trying to see if there's like any organisms in the top there. Think of like pitted keratolysis or anything like that. I didn't.
Okay.
So not much going on there. There's like a little bit of a split there in the stratum corneum, but I'm wondering, is that just artifact?
Yes.
Okay. So that leaves me with, I'm not sure.
Okay. What do you think about the architecture of the lesion?
It's kind of, I mean, it looks like a little raised papillomatus.
Yep. You're thinking too much. So what produces on the acral skin, but you see this very thick stratum corneum in a polypoid fashion with epidermal. What is it?
I shouldn't have interrupted you. You're about to help me out more. So you think of like a digital fibrokeratoma?
Yep. Yeah. It's a perfect architecture for that, right?
Yeah.
Little papule. So, yep. So this is a digital fibrokeratoma. The only thing you would need to differentiate is from the accessory digit, which you do not see any hypertrophied nerve bundles.
Right.
So this is an ADFK. Everybody good with that?
Yep. Yes.
Okay. And you have the fifth one.
All righty, we have a primarily dermal process. Location-wise, just up top, I just see thin undulating skin, and then this large ball of blue in the dermis, lots of cells with material, looks like it's interspersed in between, very granular in appearance. You know, some of the material kind of bunched up artifact to relieve. One thought I have is a granular cell tumor, just looking at the.
Yep, it's a granular cell tumor. You can see these nested aggregates of cells with eosinophilic granular cytoplasm. And here is a very beautiful pustular-void body of Million. You can see these pink inclusions.
Yes. Yeah.
Yes. So that's very diagnostic of granular cell tumor. So these tiny granules are all lysozymes. These are Schwartzian cells. So they are going to be S100 positive. This often appears as a deep dermal, a mid to deep dermal subcutaneous lesion. Clinically may appear as a cyst. The overlying epidermis can or may not show any reactive epithelial hyperplasia. So this is a nice example of a granular cell tumor.
Love
okay.
It.
Great. Let's go to the next one, which is a slide 6.
All right, here we have a large punch biopsy. It looks like somewhere like on the face because looks like there's some little sebaceous glands and everything up there. But then there's a large dermal infiltrate of some basaloid cells. At low power, it looks like there's some kind of hypocellular areas. So right now I'm kind of looking for like any sort of like palisade or like Antony A, Antony B. For like a schwannoma, but I don't see any right now. The cells themselves, I don't see a lot of atypia. You know, these look like kind of harmless cells. I don't know what kind of cells these are. I mean, maybe a little neuroid.
Okay. So what's your diagnosis?
Oh, okay. Is this a neurofibroma?
Yep, it's just a neurofibroma. It's a diffuse variant of a neurofibroma. Now, the architecture of the lesion doesn't look like a schwannoma because schwannomas are deep-seated, well-circumscribed, often encapsulated nodules. You can see how this is going into the deep dermis, even into the fat, and extending to both the lateral tissue edges. So it's pretty like infiltrating. Diffuse type of neurofibroma is associated with neurofibromatosis 1 in 20% of the cases. The cytology of the cells is beautiful for NF. You can see the delicate neuroid spindle cells in this very fibromucinous kind of a stroma, and abundant mast cells within the lesion, which are often a part and parcel of the process. They can confuse you with a DFSP in this because of, you can see how it is like enwrapping the fat. And both DFSPs and neurofibromas can be positive for CD34. But the pattern of CD34 staining is much intense in a DFSP, and in neurofibromas, it shows, or in any neural tumor, it will show what is known as a thumbprint pattern. So it looks like the fingerprints of the thumb. And also, neurofibromas will obviously be SOX10 and S100 positive, whereas DFSPs won't be. So this is a diffuse type of a neurofibroma. This is also an important board question. It can histologically mimic the hypocellular variant of a DFSP. Is that everybody good?
Yes.
Okay, next slide 7. Okay.
All right. So it looks like we have a subepidermal blister there.
Okay.
Relatively cell poor. Looking at it, I was kind of thinking between like a PCT and a coma blister.
Okay, so it is a cell poor subepidermal blister. When you see a cell poor subepidermal blister, a coma blister, it basically looks like a lacy epidermis, so epidermal necrosis. So what you see in bullous EM or TEN, that's how it will look like, but they have to give you the sweat glands to see the sweat gland necrosis, which, the sweat glands look pretty normal in here. So the morphology of it doesn't go with the coma blister. This is a cell poor subepidermal blister. And when you think about cell poor subepidermal blisters, you have to form a differential in your mind. Could this be DIF positive? This could be DIF negative. The DIF positive diseases would be EBA, porphyria, and pseudoporphyria, right? And the DIF negative diseases would be inherited epidermolysis bullosa group of diseases, like dystrophic, junctional, all those inherited EB diseases, as well as bullous diabeticorum and the NSAID-induced cell poor subepidermal blisters. So you will have to look for a second order question in this. If they don't have any second order question, they may just give you one entity like EBA, porphyria, pseudoporphyria, or any of the other things that I have talked about. So this is how you would approach this lesion.
Gotcha.
Okay, they could show you this, and then they could say that the biopsy shows, the DIF shows, donut vessels, vascular deposition of immunoreactants around the dermal vessels, and that will be porphyria or pseudoporphyria. Linear deposition of IgG3, that would be EBA, but then it could also be cell poor bullous pemphigoid, right? Because that on DIF will look exactly like EB, and that's when you use the salt split skin analysis. On the salt split skin, if you have deposition of the immunoreactants in the roof of the blister, that's BP. If it's in the floor of the blister, it's EBA. Okay? Good. Yeah, the slide number 8.
So it looks like we have some fragmented pieces here, some type of cyst. So we need to look at what type of the lining, what the lining is. Looks very thin. Looks like there's some apocrine secretion there. The lining looks very thin, like there might only be 2 layers, so maybe a hydrocystoma.
Yep. Apocrine hydrocystoma or an apocrine cystadenoma, because it's kind of little convoluted and complex, but either one of them would be the true or correct answers. Yes. So everybody good with that?
Yes.
Let's go to the next one. Sorry, guys. Again, going to leave you guys 1 minute. Have a look at this biopsy and we'll be right back. Sorry, guys. Okay.
All right, we got a shave here. It looks like we're on kind of sun damaged skin. There's some solar elastosis in the background. There's some vacuolar change, there the DEJ, and then some perivascular infiltrate, and then kind of large vessels, vascular spaces there. So to me, it looked like stasis changed to a little bit. So some sort of like PPT, because there was some hemosiderin and extravasated red blood cells as well.
Why would you see interface? You said vacuolar, right? Why would you see that in
Like an Arius. Or
so
no?
the interface change in any PPD is not really destructive. So you started very well. You call this is an interface vacuolar. What would be the second step after determining interface vacuolar? What's the second thing you have to do?
I'm sorry, say that again.
After you determine that this is an interface vacuolar dermatitis, what is the second step in your mind that you have to do?
Is it an acute or chronic?
Exactly. So what do you think is this?
Looks acute. Chronic.
There is effacement of rich pattern. There is hyperkeratosis, and you see how thick the basement membrane is?
Yeah, I do see that thick basement membrane.
So this is a chronic interface disease, and by definition, this would be what then? When you're dealing with the chronic process, you see the nice atrophy, the hyperkeratosis, the thickened basement membrane.
Yeah, like some sort of connective tissue disease.
Yep, lupus or dermatomyositis. And surprise, surprise, there's also mucin in this slide. So it's not all solar elastosis, there is mucin. Yes, there is some extravasated blood, and I cannot explain why it is. This is not on the leg. This biopsy is not on the leg. This is on the forearm. This is from a patient with subacute cutaneous lupus. So when you're talking about a PPD having interface change, it's never destructive. You do not see evidence of chronicity. Even if it is lichenoid, it's lichenoid in kind of theory, but it doesn't show, a couple of necrotic, but not a whole lot. Okay. So this, when you are saying interface, the second step is to decide acute or chronic.
Got it.
Everybody good with that?
Yeah.
Okay. And you have slide number 10.
So for this one, I see a very large thickened stratum corneum. We have elongated reedy ridges, kind of psoriasiform in appearance with vessels inside there. We have a lot of inflammatory cells in the dermis as well. But on the lateral margins, I feel like I see little cornoid lamella. Is this porokeratosis? Yep, this is verrucous porokeratosis. So it's known, it often mimics like a squamous cell carcinoma, and the buttock is like a good location for it, but it can occur anywhere, and you can see the nice cornoid lamella. So last time I showed you the center of poro, which can look interface and lichenoid, mimicking LP or a connective tissue disease. The center of poro in verrucous porokeratosis can also mimic psoriasis. So this is a beautiful example of verrucous porokeratosis. Everybody recognizes that? Yeah. Awesome. Good job. We have the next one.
Okay, it looks like we have a little punch biopsy here. Remote power. I don't see a ton. Looks like there's some stuff in the around the epidermis. It looks like there's kind of more on thicker skin. And then there appears to be some inflammatory cells in the dermal papillae. yet to be determined what those are, but they look like, oh, it looks like it's probably, I see some Caryorhexis, and so it looks like some neutrophils. So neutrophils in the dermal papillae make me think with the thicker skin, and I saw a little microvesicle on the right side. I'm thinking this might be DH.
Yeah. The only thing, make sure that when you're diagnosing DH is you're not seeing vasculitis. So, make sure that you quickly look at the vessels, and the vessels do not have any fibrin deposition, and there is no evidence of LCB. So this is a nice example of dermatitis herpetiform, this beautiful collection of neutrophils at the tips of dermal papillae. But you good with that?
Yeah.
That was very classic for DH. Beautiful slide. Okay, slide number 12.
Looks like there we have a little bit of psoriasiform hyperplasia, maybe. There's some hair keratosis, crusting there. There is some kind of super papillary plate thinning, it looks like to me, and maybe some vessels on the tips of the uvula there, but
Okay.
if there's not too much of a granular layer either, so is this psoriasis?
Okay, so it's a psoriasiform pattern, but the granular cell layer is there.
True.
See that?
Yeah.
The granular cell layer is there, but it looks a little weird. You see this?
Yes.
There is a stratum corneum on top of it.
That's a good question. Where has it gone?
It's fallen over here. Even in over here, what's happening in here? You see the splits? So there is an acantholysis involving the superficial stratum spinosum and the granular cell layer.
Okay.
Subtle acantholysis. This is pemphigus foliaceus. And the way to describe pemphigus foliaceus, the blister can be very subtle, is that your granular cell layer will look weird. So when you look at it, there is something peculiar because there is acantholysis involving, so it becomes darker looking. And you can see here that the cells are like falling apart.
Okay, yeah.
So this is, you can see here, the granular cell layer has kind of like curled up because that's where the acantholysis is occurring. So this is pemphigus foliaceus. It could also be staphylococcal scalded skin syndrome. So if they have that in the differential, then you will have to look for a second order question. But you see how weird the granular cell layer looks here?
Yeah.
And there's clearly no stratum corneum. So that's pemphigus foliaceus.
Gotcha. Okay.
Everybody good with that?
Yes.
Yep.
This is important. Like whenever I see a weird looking granular cell layer, like after some time, your eyes become really accommodated to it, but that's something that you really need to think about. Okay, we have the slide number 13.
Shade here, we got some sort of like dermal infiltrate. Lots of pale cells, lots of dark nuclei. I see those rings, so it looks like a xanthogranuloma.
Everybody good with that? It's
Yes.
beautiful two-tone giant cells. Yep, background of a fibrohistiocytic proliferation. So this is a xanthogranuloma. Great. If they don't have a xanthogranuloma in there, they can have one of those other entities like xanthoma disseminatum or something, which will also be xanthogranuloma-like. Okay.
All right, we have some parakeratosis up top, some alternating areas of parakeratosis. It looks like on this one there is loss of the granular layer. It's not as prominent as you would expect. There's vessels in the superficial dermis going up towards the epi. So it looks kind of psoriasiform, along the lines of psoriasis, but you'd also, when I see like that alternating parakeratosis, they want you to think about PRP, right?
Mm-hmm.
So between those two, to me, it looks like it does look like there's like super papillary thinning with those vessels up there. So I was leaning more towards psoriasis.
Yes, this is actually beautiful for psoriasis. So it's almost forming like a guttate lesion of psoriasis. So PRP will not have neutrophils in the cornified layer. You're clearly seeing newts in the cornified layer in here, right?
Mhm.
And PRP also will not have diminution of the granular cell layer. So you can actually see that the granular cell layer here is absent.
Mhm.
So
Okay.
the pattern of cornification is not really checkerboard, plus the presence of neutrophils. You see here, there's actually neutrophils actively pouring out into the stratum corneum.
Oh yeah.
And there's loss of the granular cell layer. This is beautiful for psoriasis. And then and this is more in the guttate form because it's not a fully well-developed plaque, but you can see it's starting to happen. The bulbous very ridges, the dilated vessels, and this is kind of like your stuck mound and the elevated mound.
Okay.
So this is very, very diagnostic of psoriasis. So good job. Next one is a 15.
All right, so even at this power, we can see that there are large, elongated, potentially perivascular or neurovascular, lymphoid infiltrates. There's a couple, a little bit of superficial inflammation, but it does go pretty deep.
Mm-hmm.
I get a couple different thoughts depending on what I see when I get closer in, but my first thought when I see this denser cuffing that's mostly lymphocytes is EAC.
Okay.
Erythema. I'm not seeing many granulomas, but if I saw granulomas in there, I would also consider leprosy. Those are the two biggest things I think of when I see these large swaths or these sausage shapes.
Okay.
What else? When we have superficial and deep inflammation like this, also got to consider like lupus, especially if there's yeah.
Okay. So if you're thinking about EAC, this is a pattern of the tight lymphocytic cuffing.
Yeah.
Right? So it's a cuffed pattern, which you will see in gyrate erythema versus
versus like lichen striatus.
Tight perivascular cuffing. Here, the epidermis is completely uninvolved, right?
Tumid lupus, if it's
Yeah,
uninvolved.
this is tumid lupus. You can actually see mucin.
Mm.
So the only way to distinguish between EAC and tumid lupus would be to look for the presence of mucin, right?
Yes, I didn't want to trust the mucin.
Okay. Not scared of the mucin in my presence, no. But there is, so for this entity, it's important. The only way to distinguish between tumid lupus and EAC, this is a very lupus-like infiltrate. The tight cuffing going deep down, even around the sweat glands, around the nexal units, and with the mucin. This is tumid lupus. Everybody good with that? Yes. It's a very important board slide. Okay.
Okay, it looks like we might have a shave biopsy on some sun damaged skin. Looks like there's a band of solar elastosis with very atrophic skin or epidermis. I see a lot of vessels as well with some perivascular lymphocytic infiltrate.
Mm-hmm.
I can't think of anything more specific than
Chrissy?
something like stasis.
Okay. Chrissy,
Um,
can you follow up on that nail case that we sent Lebois?
Yes.
The self-pay patient. Yeah, thank you. Sorry about that, guys. Yes, go ahead.
oh, it's fine. So stasis is high in the differential for me just because of how much, how many vessels there are. The epidermis is hard to see what's going on because it's so atrophic, but I don't know if there's a little vacuolar interface or not. I don't see any, pigment dropout. So unless this is like, if that's a true, is this a vacuolar interface?
It is.
Okay, so it's definitely chronic.
Yep.
Without atrophic the epidermis is. So anytime you see vacuolar interface, then you're going to ask acute or chronic.
Yep.
So it's either is it dermatomyositis or lupus.
Yep.
Would this just be dermatomyositis?
Yep. Why are you guys all going down the stasis route today? Stasis.
Well, I saw the vacuolar thing, but it's so thin I couldn't tell.
Stasis actually has a thick epidermis. It's either ulcerated or thick. I've never seen an atrophied epidermis.
Oh, I always imagined it to be on like really like sun damaged legs where it's like they're super thin, but
no.
That's my imagination playing tricks on me.
Nope, they look like cannonballs with a thick epidermis on the top. And if it can be ulcerated if there is an associated stasis ulcer.
Well, if Cade wouldn't have suggested stasis, it wouldn't have been on my mind.
I know, right? Like, let's all blame him. But you see how beautiful the thick the basement membrane is?
Oh, yeah, now that you pointed out, I can definitely see it.
And the squamatization, the atrophy, the hyperkeratosis. And this is from a patient with dermatomyositis, and you often get telangiectasia of the vasculature. And that's why that's looking prominent in over here. So this is dermatomyositis. Everybody good with that? But it could very well have been lupus as well. So either they're going to give you one or they're going to give you a second order question with it.
Okay.
Good job. Then you have the next one is 17.
Well, it looks like we have a kind of exophytic papillomatous lesion here. Got some real hyperkeratosis that's pretty eosinophilic. Got some kind of chunky looking cells there at the base. It made me think of Verruca, which is Verruca vulgaris, or
so it's got the architecture of a wart.
Yes.
But it's got features which are not going with the wart. You are seeing the hypergranulosis, but then you're also seeing these kind of pink inclusions with the cytoplasmic clearing of stratum spinosum. Do you see that?
Yeah, so it was dyskeratosis.
Is it dyskeratosis, the pallor with these pink inclusions inside the epi? So what causes the pallor of the stratum spinosum with pink intracytoplasmic inclusions along with the prominent granular cell layer?
You think of something like epidermolytic hyperkeratosis?
Yep, this is EHK. And it will mimic a wart. That will be in your differential. That's how exactly you will differentiate it. Now, do you see the pallor?
Yeah.
And the pink inclusions? These are all clumped cytoplasmic keratine filaments. There will be hypergranulosis with it, but a wart won't give you that pallor. And in a myromystial wart, if you are seeing the pink inclusions, they are very prominent. They are much more thicker and bigger. Okay, so this is EHK. So then they can ask you plenty of second order questions. Could be an incidental finding, could be seen in congenital bullous ichthyosiform erythroderma, ichthyosis bullosa of Siemens. It could be seen in, an epidermal nevus. It could be seen in the palmoplantar keratodermas. Okay. Everybody good with that?
Yes.
And then they can ask you the keratin mutation with it. Okay, next one is 18th.
So we have regular acanthosis. It looks like there's a, in the stratum corneum, there's lots of like dirtiness going on, like maybe neutrophils, or might be like a subcorneal split in there somewhere.
Mm-hmm.
So my first thought, just like looking at that, is like potentially like organisms that you would want to stain for. I don't really see a granular layer anywhere. So you could also think of like a pustular psoriasis.
Yeah, this is classic plaque of psoriasis. It has got all the features. You see the beautiful psoriasiform epidermal hyperplasia. You can see the bulbous VD ridges, the suprapapillary thinning, the dilated vessels, beautiful Munro's microabscesses, neutrophils actively pouring out, and there's almost a complete absence of granular cell layer. So this is a beautiful example of the psoriasis, a plaque of psoriasis. Everybody good with that?
Yes.
Mm-hmm.
Next one.
Right, we have kind of a cup-shaped invagination into that, here filled with keratin debris. There's little bulbous extensions of the epidermis there. So I thought this looked like a dilated pore of Weiner.
Yep, great job. Everybody good with that?
Awesome.
Okay.
So we have a square punch with a large process happening for most of the deep dermis. It doesn't appear to be connected to or coming off of the epi. It looks like it's almost pushing up into it from here. The cells themselves, I'm not 100% sure who they are, but I don't like them. They don't look very nice. They don't look friendly.
Okay.
They're kind of balling up into little islands here. Is this maybe like metastatic carcinoma, potentially breast?
So a breast wouldn't ball up like that. This is forming nests. You see that?
Okay. Okay. So
And
more like melanocytic cells.
this is metastatic
Nevoid cells.
melanoma. And do you see, it's amelanotic, but do you see the prominent nucleoli, the cherry red nucleoli?
Yeah, yeah.
So and the nesting pattern and this very angry nucleolus. This is classic for a metastatic melanoma.
Gotcha.
Okay, it's an amelanotic one, and it's undergone, the center part of it is all tumor necrosis.
And
Yep. So this is metastatic melanoma. Everybody good with that?
Yep.
The prominent cherry red nucleoli is something you should remember, and the nested pattern in the amelanotic variants.
perfect.
Okay, good job. 21.
We have a shaved biopsy, what looks to be on an acral surface. Little bit of acanthosis. And then over here on the right side, I don't know if that's artifact or if that's an actual split there. Some acantholysis.
Acantholysis?
I thought there was. I don't know. I wasn't sure if that was acantholysis more to the left, but
Okay, carry on.
in that area. But and then we see some superficial dermal infiltrate. I thought I saw some red blood cells, lymphocytes, and some dyskeratotic cells here.
Yep. It's not acantholysis, it's dyskeratosis.
Dyskeratosis.
So what does it become when you see dyskeratosis?
I mean, my differential at that point would be things like Darriers, Haley, Grovers.
Mm,
No, I don't think those things.
so it's not acantholysis. what do you mean by
Oh, yeah.
disc keratosis? Disc keratosis means dead cells.
Perfect.
Pink cells are dead cells. So when you see dead cells in the epi, which disease process, under which category would you like to put it?
I don't know about categories. I mean, I think of fixed drug when I think of.
So yep, this is interface, right?
Yeah. Oh, okay. So
When you're seeing necrotics, you're seeing interface. So then the second step is what again?
then you ask acute or chronic.
Exactly. And what do you think, acute or chronic?
Let's see. I don't see it being very acute, so I would say it's chronic.
Why do you say it's chronic?
Well, I don't have any clues. I mean, clearly there will be some, but it being on acral surface, I don't see any like acute changes, like any crust or.
Does that make acute or chronic? Acute or chronic? What's the definition of acute versus chronic in an interface process? What makes a chronic interface? It's not the crust.
It would be like effacement of the reedy.
Yeah, epidermal atrophy, hyperkeratosis, effacement of the reedy ridge pattern, which is epidermal atrophy, and thickening of the basement membrane, right?
Uh-huh.
So this is on this, yeah. So this is not chronic.
Because we don't see effacement of the reedy, we don't see basement membrane thickening.
Thickening, exactly. So this is an acute process. So acute interface, what are the 4 things that you think about?
So then I would say so I'm going to think fixed drug, PLC or pityriasis lichenoides, EM, graft versus host.
Exactly. So which one is this?
If it was fixed drug, I'd look for pigment dropout, and I don't think I saw any.
Yep, there is very subtle. It's very subtle. So it's not within the fixed drug range.
Graft versus host would be posse inflammatory, so I don't think this is graft versus host.
Yep.
And then PLC, there'd be more stratum corneum changes. So this could be PLC. I mean PLC versus EM, but EM would have probably pigment. They wouldn't have pigment dropout. So maybe pityriasis lichenoides.
It's EM. It's erythema multiforme. Yes. It's a beautiful location. Yep. Yeah. So you differentiate between the two because first of all, do you see how in pityriasis lichenoides, a more prominent feature is lymphocytic exocytosis. The necrotics actually are not that prominent. Here you can actually see high level necrotics. You see that?
Yeah.
So to me, EM and fixed drug are somebody sitting down in the dermis and shooting at the epi. So when you see necrotics at varying levels in the skin, that really makes you think about EM or fixed drug. And in pityriasis lichenoides, even though it's interface, the necrotics are not that prominent. Unless and until it's a Mucha-Haberman variant where you actually get epidermal necrosis and ulceration and it's a deeper infiltrate. And what is more prominent in pityriasis lichenoides is the lymphocytic exocytosis, so prominence of lymphs in the epi. Okay?
Okay.
Those are the differences. So this is EM. Everybody good with that?
Yes. Yep.
And the hand is a nice location for EM, right?
Yeah, that's true. Yeah.
Not so good for pityriasis lichenoides. Okay, slide number 22.
All right, looks like maybe there's a little bit of perivascular infiltrate there. It seems like there's kind of possibly some interstitial histiocytes mixed in there. I don't want to say it, but I might have to. It looks like there could be mucin in there.
Yep, there is.
Okay. But the kind of combination of those 3 things made me think of an interstitial GA.
It's actually classic GA, but that's good. Very good. You can actually, you see this? This is the dead area.
Okay, yeah.
Necrobiotic area, which has mucin in it, and all the lymphocytes and histiocytes are collecting around it. Interstitial is the individual collagen bundles are swollen. Here you do have a distinct area of necrobiosis with the palisaded infiltrate around it. So this is classic GA.
Okay.
but good. Yes, very good. And it is pretty common in GA to have an accompanying superficial, deep, or mid-dermal lymphocytic infiltrate.
Okay.
We've got a very superficial shade here. It looks like the epidermis is really atrophic. My eye is drawn to the blue area and the dermis here. Looks like it's something. At first, I was like, "Is this ciliary elastosis or is it like some sort of deposition?" So probably more like a mucin. It's kind of diffuse. It's really possy inflammatory. There's a few inflammatory cells, but not too many. So you might think of like a pretibial myxedema.
What if it was one lesion?
Like a focal cutaneous mucinosis.
Yep, that's exactly what it is. Good job. You approached it really well. Okay, 24.
I might need a little help on this one. So it looks like part of the epi, there's kind of some PEH change going on there. And then there's these enlarged vessels. And then there was some spots where I thought I saw, like sebaceous glands. It looks like we're on the face here. And then at the bottom there, is that like cartilage maybe? Like plain cartilage? So you would think of CNH.
Yep, that's exactly what it is. And it's beautiful for CNH. Even it didn't have the cartilage. These changes are very classic, where there is dermal fibrosis, often mixed with solar elastosis. And then you can see the nice telangiectatic vessels. There is hyperplasia as well as there can be erosion as well as ulceration. But here you do see the cartilage, which is a very nice clue for CNH. Good?
Good.
Okay, 25.
$25 is kind of a little bizarre looking. We have lots of dilated vessels, potentially cup-shaped invagination here. This mound of cells coming off of it. It also kind of looks like it's falling apart in some places, and some of the cells look a little bit irregular. Could this be an acantholytic squame?
You see how well defined this lesion is? This is all normal, right? You see the beautiful cup-shaped invagination?
Yeah.
This is very well circumscribed. And what is this?
Hyperkeratosis or hypergranulosis?
Yep, with? What is this cell?
Keratinocytes?
This is acantholytic disc keratosis with chorons and core grains.
Oh, okay. So it's like a warty D?
This is a warty disc keratoma, and they will have a acantholytic squamous cell in your differential.
Okay.
But this is very well circumscribed. You see that? And the surrounding epi is like completely normal. Wherever you're seeing the chorons and the core grains is where you see some kind of like reactive atypia to the epidermal keratinocytes. But everybody recognizes the beautiful chorons and core grains?
Yep.
So this is a warty disc keratoma.
Gotcha.
Okay. The next one is 26.
Okay, we have a punch biopsy.
Okay, this is a classic example of this entity. Okay,
I
go ahead.
hate when you say that. Oh my god.
It's okay.
Oh, no.
It's okay.
So some hyper orthokeratosis, looks like a strong granular layer, and then in the papillary dermis, there looks like.
Where do you think potentially this lesion is located?
I mean, maybe like an acral surface because there's a stratum lucidum.
Exactly. So this is on the acral skin, and on acral skin, okay, go ahead.
No, I mean, what were you gonna say? So I do see, and then in the upper, the papillodermis, it's kind of acellular, less so than, the reticular dermis. I don't think it's like a strong amyloid, but like it could be like amyloid doesn't really occur on the hands, like a macular amyloid. There's some
Okay,
lymphocytic
so
infiltrate.
look, tell me one thing. If this is acral skin, what do you think about the thickness of the epi on the acral skin? Of the stratum spinosum on the acral
Right
skin.
there, it's really thin.
Exactly. What produces a thin epi on the acral skin with this kind of what you are describing fuzzy amyloid is
Yeah.
actually a fuzzy basement membrane. You see there is interface.
Oh, okay. Yeah, so that's such a huge interface.
Oh
then.
yeah, it is a massive basement membrane thickening, chronic interface. And then you see all these telangiectatic vessels.
Is this a dermatomyositis or
This
something?
is Gottron's papule.
I think that's like
And the
3 for 3 or 0 for 3 for connective tissue disease for me today.
it is difficult. You interface group of diseases, those acute and chronic, lupus, dermatomyositis, EM, fixed drug pityriasis lichenoides, they are challenging. This set heavily focused on that. So I want you to go back and look at the cases. These are beautiful examples of each one of those entities. So this is dermatomyositis. You've had a bunch of connective tissue diseases. I do want to 27. So everybody got that? That's classic Ford Gottron's papule.
Classic. Yes.
27.
Wow. It looks like we kind of have some areas of almost invaginated hyperkeratosis there.
Mm-hmm.
Acanthosis, the epidermis. When maybe I was looking at it too long for too close, but when I started to look at the epi at the areas of invagination there, it looked like it had some coarse hypergranulosis there as well. It made me start thinking of things on the warty type differential, like condyloma, acuminata, something like that.
Okay. Marked acanthosis, hypergranulosis, everybody agrees.
Yes.
Agree?
Yeah. Yep.
If you're paying attention to the epi, you will actually see that there is marked irregular acanthosis and hyperkeratosis. You beautifully described the hypergranulosis. See the hypergranulosis?
Yes. Yes.
It's actually in a wedge-shaped pattern.
Yes,
But also notice what is happening at the D junction. What is all that?
Kind of thick lichenoid infiltrate there.
Exactly. And the bottom of the epi, instead of being a wart-like flat and bulbous, what is it?
Or sawtooth.
Exactly. And wherever you have the sawtooth, you will have the vacuolar alteration. So there is like the max dose of space. You see that?
Yeah.
So what is this?
I guess it's LP.
It's hypertrophic LP.
Hypertrophic LP.
So
Okay.
hypertrophic LP presents with marked epithelial acanthosis, hyperkeratosis, wedge-shaped hypergranulosis, so that attracts your eyes. The bottom, even though it is thick, it's actually irregular, jaggedy, sawtooth-like, and the lichenoid inflammation over a period of time dies down. And what is left behind as a telltale sign is the jaggedy sawtooth. But here you do have the lichenoid pattern as well, and you can see the cytoid bodies.
Gotcha. Okay. That's
This is
good.
beautiful hypertrophic LP, and the bulbous epithelium, which becomes thick, looks pink.
Gotcha. Okay.
Classic example of hypertrophic LP. Great job. 28th.
We got a punch biopsy. It looks like there is a sparse, superficial, and deep infiltrate in this punch biopsy. From afar, there might be some sort of like, some of the cells are at the DEJ right here, some sort of like interface process. It's leaning more towards like a connective tissue process, I think.
Acute or chronic? So you're saying acute or chronic? Chronic.
It looks more kind of like thinned out, and it's not super inflammatory, so it's like more of a chronic process.
This is acute.
Acute.
Because you see the stratum corneum. The stratum corneum is actually very acute.
Okay.
And you see the necrotics again. How do you describe the necrotics to be? Some at the bottom, some at the top.
Yeah.
See that?
Yes.
So this is again a pattern of the shooting epidermis. Somebody sitting down over here and shooting the epi.
Okay.
And this is fixed drug eruption. You see the pigment dropout?
Yes.
And there are eosinophils in the infiltrate. Let me see you. So this is fixed drug eruption. Yep, go ahead.
What
See
about
the ears?
the epidermis shows that it's acute?
This is very acute.
And like, because I thought it was supposed to be more like hyperkeratotic, no basement membrane thickening.
So this is acute. Yep.
But it's not
Hyperkeratotic.
hyperkeratotic.
So that's why it's acute.
Oh, you're saying, so it's, I see. Yeah,
Yes.
I'm like, we're both like arguing the
And-
opposite. Okay.
And you know what? If one of the pattern confuses you, you again see the recognition of the necrotics.
Yeah.
You see how they like up, down, up, down. Lupus, it produces vacuolar, but it doesn't produce this much necrosis.
Okay.
That's also indicative more of acute if you are getting confused. Plus the stratum corneum in here, this is, you can see it's basket weave in there. And you can clearly see the pigment drop out and they are eosinophils. So this is fixed drug eruption.
Nice.
In that theme, so these are all classic guys for this entity. The 29th slide. So I wanted to, okay. This is a little different. So which category of disease this is? This is not interface, obviously.
Up on that last slide, it looked like we have a subepidermal split here. Predominantly looks like we have neutrophils within.
Exactly.
So my first thought was like linear IgA, DH, or
bullous lupus.
Bullous lupus.
Or chronic bullous dermatosis of childhood.
Yep.
So then they'll give you a second order question and you'll pick it up. This is from a patient with linear IgA. Okay?
All right.
Good. I thought I had that slide, and don't tell me, oh, good Lord, I did not. I thought I had a slide of pityriasis lichenoides chronica. Next time, guys.
Next
time, we'll be ready.
Okay, so tell me about 30. Is it interface?
It does look to be interface to me, maybe even vacuolar in a couple places, like here. Thinned epidermis, very atrophic, kind of pushing me towards that connective tissue direction.
Exactly. So this is chronic. You see that?
Yeah.
You see the thickening of the base membrane, the epidermal atrophy, the hyperkeratosis, and you pay attention to like how the necrotics are. The necrotics are there, but this is an atrophied epidermis and mostly located in the basal layer. In contrast to this pattern, see the pattern of necrotics here? It's different. So sometimes that can help in the recognition if you're not getting the thickening versus the thinning of the basement membrane. And I really thought I had a slide of PLC in there. If not, let me just see. I may have it around in here. See, I can. Okay, let's see in here. Let me just pull my. So this is also an interface. You can see vacuolar,
Yep.
but again, you see it's acute, the stratum corneum. And you see that the limbs in the epi are very prominent,
Yeah.
more than the necrotics you see. You could come up with an acute interface. You do see necrotics. You can see here the necrotics in here. And it's obviously vacuolar alteration, but the limbs, sorry guys, let me just take this out of the stage. I'm going to drive it the way I want it so that I can explain it to you. So it will be a little upside down, but everybody knows it's vacuolar because you see the nice holes in the space, but you see how the limbs are prominent in the epi?
Mhm.
There's a necrotic there, but the limbs are very prominent. That's a feature of pityriasis lichenoides.
Yeah, sure.
You see that?
Yeah.
Yep.
Along with, the other features that you will see from the top to bottom. So there is going to be like the crust formation. So you can see here the paracavatosis. You can see the limbs in the epi. You can see the necrotics. This is a shave biopsy, but there will be a perivascular lymphocytic infiltrate. You can see extravasated blood. So all of that will be pityriasis lichenoides. But really, the limbs in the epi are so much more prominent than in any other interface disease, even though the dead cells in the epi are occurring because of lymphocytic exocytosis, but for some reason, it's more prominent in the pityriasis lichenoides group of diseases. You got it?
Got it.
That's a good one.
Yeah, it's good.
Okay. So yeah, so your homework for today is go back and look at all these slides and chalk out the acute and the chronic.
Sounds good.
We'll do it.
Okay. Guys, I will not be able to do a class next week. I have to travel to India. My father-in-law in India passed away. So
sorry.
I have to, I have to visit. I'll be gone for like a week. I'm leaving this Saturday, so I won't be able to do the Tuesday class.
Okay, no problem.
Travel safe.
Okay. Thank you.
Thank you so much, Dr. Iman.
Thank you.
Thank you. Have a good day.
Will do, you too.
Thank you.